Hello, everyone here. Well, we are here for our next step. I think that we've been working a lot together, alone, in our countries, in our professions, but now we have to get to the next step. Every pediatrician of this meeting is to help the most amount of children around the world. So that's what I want. Know that I'm an orthodontic, a pediatric dentist, but I'm working with kids of 3, 4, and 5, not for aligning teeth, but for know that I can be part as orthodontic, getting them to the high potential, helping them to chew, breathe, and talk better. So I think that all of us are for the same reason, but we have to go to the next step. And we were talking today with Gavar, and the thing is that we have many titles and many things that we do, but we have to be there all together, going through the same direction with the same title. I think that we are creating another specialization, and we are not talking about putting teeth align. That's why Mark, today we're talking, I said, I'm an ex-orthodontics. I don't know now what I am, but I want kids to be better. And I know that we can do part of the team. We orthodontics are part of a team to do that. But are we orthodontics? Can we call this orthodontics, postural orthodontics, myofunctional orthodontics? I don't know. You are in the video. I think that's what we have to do, to go to the next step.
Yeah. If you're just tuning in, I want to welcome everyone here for our live event. This is discussion panel of track 3, Orofacial, Myofunctional Therapy, and Orthodontics. We have assembled here today key panelists who are leaders in their fields around the world. Marissa Santos is here speaking with us as the moderator, and we're going to hear from many others. So thank you, Dr. Santos. And did you want to say something, Mark?
Yeah, really quickly. I hope the buzzsaw from our neighbor's yard doesn't really drown me out. But it's a real honor to be here and to have this track around myofunctional therapy and orthodontics. So from the perspective of, I think, everyone here, you cannot separate myofunctional therapy and orthodontics. Although when you look at the guidance statements or position statements or policy with major leading orthodontic societies, including the American Association of Orthodontics, that fundamental pillar or tenet is missing. But we had in our keynote presentation, a presentation from Dr. Takashi Ono, who we gave a Lifetime Achievement Award, our top award, the Hippocrates Award, which is really about changing medicine. And Takashi Ono is chairman of the World Federation of Orthodontics meeting, and also as department chair at Tokyo Medical Dental University, gets 35 new PhDs a year. At the same gala a week ago today, we gave the same award to Dr. John Mew, who's on this panel, who might be, kind of considered more on the fringe of the orthodontic profession. But if you really listen to the messages in their presentations, they're talking about the same thing. So I think we're at a really exciting time of perhaps a tipping point in orthodontics. And I hope we can discuss that today as we explore what we think might be wrong with orthodontics and what we might be able to do to change it, or perhaps to put into a white paper. Now, we had a discussion earlier today about perhaps the need for having a white paper on orthodontics and myofunctional therapy, which is really its own separate thing. So I just want to open it up and challenge all of you panelists today. So if you want to go forward, Marissa and Gabor, welcome, and go ahead and carry on with introducing the other panelists as you will.
Hello, everyone. Thank you for the opportunity. So just briefly about myself, so I'm an orthodontist in Budapest, Hungary, and I've been doing functional work for many, many years. And definitely I agree with Marisa. So there are basically two problems. So number one is this position at the moment of the mainstream orthodontics, the academic orthodontics, because they still believe that the problem is isolated and isolated locally and isolated to the structures. So this is the number one problem. So we have to define that kind of orthodontics, which is different from the mainstream. So definitely we have to go back and define subspecialties or subcategories within the orthodontic specialty. And problem number two, as Marisa said, so we have to make a consensus. So those who have been agreeing upon that we have been doing something much more comprehensive rather than straightening teeth. So we have been working together with orofacial myofunctional therapists, body workers, and breathing therapists, and ENT and sleep. So definitely we have to make a kind of standardization. So what we do, which is the process, and what we call it to. So actually, definitely we have to agree upon names and definitions, and we have to provide something to the orthodontic world to understand why is it different what we have been doing. So these are my my problems that this is my problem is that I would like to introduce to you. So let's go on with the people. So just according to the names. So John, please introduce how you see the problem, please.
Mike, maybe it's best if we start with you. Mike Mew?
Yes.
All right. So it seems to be a great forgotten acknowledgement that within dentistry as a general, way beyond orthodontics, within the whole of dentistry, we know that the teeth, the alveolus, the periodontum, and the supporting structures for the teeth sit in a balance zone between the soft tissues, the tongue on the inside, the lips and the cheeks on the outside. I mean, this is widely acknowledged. And yet, we seem to be spending so much time aligning teeth, and yet so little time trying to change the pattern of behavior, so with the posture and the function of these soft tissues. Now, this just seems very, very strange to me. You know, I think I could pick up textbooks on orthodontics, and few of them mention myofunctional therapy at all. And yet we know, we know that this is a very, very important adjunct. In fact, maybe we could say that orthodontics is an adjunct to myofunctional therapy. But the biggest and possibly the most important thing right now that I see is that there are hundreds of thousands of people, probably millions, who wear retainers at night after their orthodontic therapy. So we've got lots of people wearing the retainers, and now a retainer is very good at holding the position of the teeth. It's excellent at holding the position of the teeth, but it can't hold the position of the supporting structures. So we're effectively holding teeth out of their balance zone. And quite a few countries have recently acknowledged the need for long-term retention, or rather the instability of orthodontic results. And of course, if you have this instability of orthodontic results, people are asking or recommending long-term retention. And I think this is a shame, because we shouldn't be recommending long-term retention. We should be considering how we can affect people's soft tissue balances. This is screaming out that we should be affecting people's soft tissue balances, because in the long term, holding teeth out of the balance zone can only be a bad idea. And For that, we need to resort to myofunctional therapy. And we need to make myofunctional therapy as ubiquitous as permanent retainers, or we're storing up just for people who are treated, even people who are treated without myofunctional therapy, a long-term problem for the future.
And we know that retention is because they don't achieve the posture. But how can we put this together, all of us, and creating something that we all work together, because we know that my function is more important than our treatment, our active treatment. But
well, okay, what can we do about it? Well, we can start to spread the message that this exists. Most people are not even aware that this is existing. I mean, you know, you need to spread the message by telling people, something I've been trying to do. And with this conference, I mean, the specific angle of this conference is the first 1,000 days. So how can we prevent these problems arising in the first place? How can we talk to parent groups? We can talk to all the professionals involved in the first 1,000 days of a child's life, and tell them to make them aware that these possibilities even exist.
Could we have Sabina Sakamano say a few words?
Dr. Sakamano, just to introduce her, she's author of some really exciting work on myofunctional therapy and Down syndrome, myofunctional therapy and orthodontics, and she's co-editor of a great new textbook with Licia Kociani-Pasquet, which came out of an orthodontic textbook, New Trends in Myofunctional Therapy, which, you know, maybe is like the first modern textbook in myofunctional therapy in English. So thank you, Dr. Sakamano, for your work.
Actually, if you don't mind, this is Licia. Sabina asked me to help her out because she is not very comfortable in speaking in English. So she allowed me to speak not only for herself, but also for the entire Italian team. And as you might not know, or you might know, Sabina is an orthodontist and I'm a speech pathologist and myofunctional therapist. And we found the perfect combination because, as I said in my note over here, we are dealing with two faces of the same coin. And we feel that we are both indispensable, but where we should really focus our attention at this point is trying to educate people about the prevention, starting very early and using normal function as a preventative measure so that people eventually don't need us. We want to work ourselves to extinction in a sense. And so, and also the presentation that the two presentations that she organized with the team at L'Aquila University in Italy take into account this new development, which is the use of telemedicine or telepractice that can be actually very important even for orthodontists to keep in touch with patients more often, to motivate them, not just to, you know, whatever they need in the orthodontic arena, but especially when along with an orthodontic treatment, you have at the same time, before, after, etc., a myofunctional treatment and or a breathing treatment, because we have to look at the importance of function. So breathing comes first. And so telemedicine has been really a great adjunct to what we are trying to do. And probably in the future, it will allow us to reach a much larger pool of professionals, but also patients, you know, so that we can educate them on the importance of working together so that they don't think about, well, I'm going to go to the dentist, is only going to straighten teeth and that's it. And, you know, some people just go with wild eyes when orthodontists talk about myofunctional therapy and vice versa. So that's that was the core of her presentations, plural.
Okay.
Licia Kociani Pasquet is founding president of our society and a colleague. And it's exciting to have her here kind of helping build bridges between the great work that's been done in Italy in myofunctional therapy. We had our first scientific meeting in Italy 6 years ago, and we had our third Congress in Italy just 2 years ago. And it really finding ways to build bridges around the world in order to advance this is really part of our work. I don't know if maybe we lost Miho, but Kevin Boyd is back here.
Kevin.
Yeah, hi, Marissa.
Hi.
I really like what Mike said is orthodontics, at least, you know, in early childhood, should be seen as an adjunctive to myofunctional therapy. That was like revolutionary, Mike. And I really, it sums it up, is that myofunctional disorders, they underlie all etiology of malocclusion in non-syndromic children. They're all because of myodysfunction. So I think that could be a goal for a white paper, is how we shift the thinking. And Mike, that is like awesome. I just like, that's really all I want to say, you know.
Thank you, Kevin.
So one of the things that I think is important to note that the term myofunctional therapy, even though it maybe existed in different formats, was actually, you know, it's credited with having been coined by one of the fathers of the field of orthodontics, Alfred Paul Rogers, who at Harvard's orthodontic program gave a presentation to the Angle Society in 1918, really introducing myofunctional therapy. And he spent the better part of his career really kind of fighting to say that soft tissue is always going to trump bone, and that tongue posture was a critical part of overall health, not just oral health, but systemic health. And I think, you know, orthodontics went a different direction, as we all know, maybe more in a production line model, inspired by even like Henry Ford in the 1920s. But I think orthodontics, there's a great strong movement to consider, you know, the occlusion, malocclusion, development of the craniofacial morphology as it relates to overall health. So I think this is a really exciting topic and something that definitely warrants exploration.
Yes, Miho is back, so let's give her the opportunity, and then we can get back to this topic because it is very important. So you have made two important statements. Number one is there is a movement in the orthodontic specialty, so we have to divide different categories within the orthodontic specialty, and we have to talk about the systematic health impacts of the mutual job what we have been doing together with myofunctional therapy. So Miho, are you back? So do you have the microphone?
I'm afraid her video is not working, or we can't connect with her.
Well, I would like to acknowledge Dr. Imamura. She's one of the founders of the Japanese Society for Myofunctional Therapy. And she was on the second board of the AMS. And she's been someone who's been very ambitious about building bridges around the world between disciplines and between specialties, and helping share knowledge of myofunctional therapy around the world.
Can I say a word?
Certainly, please, Dr. John Mew.
In my mind, the main problem is the orthodontic training, which concentrates on straight teeth. And very few orthodontists are taught about orthotropics, or shall I say, posture and the influence of posture. And I have found most of them will not even consider listening to statements about it. We must remember that their entire training is based on mechanics of alignment. And another factor which inevitably will make a difference is that their livelihoods come from providing treatment to straighten people's teeth. and they are not really interested in facial appearance, although most patients themselves find their appearance more important than the crowding of their teeth. That's all I'd say. Thank you.
Thank you very much.
Hey, Mark, I don't know if you hear me now.
Yes, we can hear you.
Okay, I think, if you are an orthodontist and you want to go to the way of myofunctional therapy, you need always to think to, when you do your treatment, never to reduce the place of the tongue of the airway. It's like, you need to limit the extraction or the retraction of the arch, because one of the big problems for the people who do an orthodontic treatment is to find the place to place the teeth, and in this way, the best way is with the limit, the best way is to do expansion, distalization, but to limit the extraction and really to not to reduce the place for the tongue or for the airway. It's really a way we need to go.
I think that's a wonderful comment, and I think that's fantastic. Thank you. I mean, it's a dream for us to be able to say this on this panel, but in order to get really, focused, position papers and standards of care with national societies, we have a lot of work to do, which leads me to a comment I just was texted from Dr. Terry. She mentioned that she wanted to say that what we need to focus on, one of the things, is that to create a network of colleagues and show our results on patients. And so I'm really glad to have her as a research collaborator. And I'm excited to say, this may be a little bit premature, but in my day job, separate from the society, where I serve as a volunteer and Samantha Weaver serves as a volunteer, we work in an institute, the Academy of Orofacial Myofunctional Therapy, which is working with INSERM, the National Institute of Health of the government of France. And we're really excited about a research consortium we're developing and having a REDCap research database where we envision having tools and resources for orthodontists to collect data, so to have standardized ways for you to share objective measurements and also for patients to give data. So we look forward to getting that. And actually, I've been looking at server space this past week. So thank you very much, Corinne, for your comment.
The most important thing for me is to start early, because last time I went with Professor Guilleminot in the American Congress of Orthodontics. They say that treating early is 7 years old. For me, 7 years old is someone that is like a very, very ancient man. So we have to put them. So I said, if all the papers show that growth is in 1, 2, 3, the kids know how to chew, to breathe, to make the exercise, the rest position. Why we are treating at 7? That's a problem that the American Association says behind Guilleminot, saying, please girls, I was there with Sandra Khan, please treat early. And there was a panel saying, treat early, make a consultation at the age of 7. That's a problem we have. That's why we have to go to pediatricians, because it's there. They have to know that this is different, that we have to start at the age of, with a baby, but that treatment at the age of 3, 4, 5, not at the age of 7. So, but the case is, what can we do to change this? Because we all know that we know each other, but what is our next step? How can we reach pediatricians?
That is a very, very good question. And I know there are some pediatricians in our community, and they all talk about the training of pediatricians is to really look at research with randomized controlled trials, and that's what they gauge their recommendations on. And I think that's part of the challenge here, is not having this level of research for that community to say, oh, this is without doubt what we would do and what I recommend. However, if they understand the preventative aspect in this arena, I'm sure that they will understand the developmental impact that we have on the whole system. So I feel like we have to bring them in. We have to bring them in a concerted effort and to invite them into this arena.
Yes.
I think that's a great comment, Samantha. And I would strongly encourage everyone to see Takashi Ono's keynote, because they figure out a way to induce mouth breathing in rats, you know, create myofunctional disorders, little baby infants. And they got really scientific measurements on the development of high narrow palate, on retruded mandibles, smaller mandibles, larger tongues, tongues that create tongue thrust, actually. Motor mapping of the masseters being diminished and disorganized, and lack of really clear brain activity, and also diminution of the fungiform papillae. The taste buds were smaller. So it's going to change how they choose their food, the quantity, the saltiness, the fattiness, and even, you know, GLUT4, you know, being upside down in its levels. So maybe there's like a correlation to diabetes, or, you know, early onset diabetes. You know, these are all profound things. And I can't wait until we can get a center trained at Tokyo Medical and Dental University of high myofunctional therapy clinical competency, so we can actually start working with humans. But, you know, Dr. Mew said, you know, talking about early intervention, early as possible, Mike Mew, that was such a fantastic idea. And this is really about the formation of an International Pediatric Orthodontic Society. Licia Pasquet in our speaker chat room was talking about, when should it start? Should it start at 0? Absolutely. We should reimagine the first 1,000 days of life. And Kevin Boyd has even talked about, you know, formation of the mandible in utero, and certain factors which may be impacting that, you know, retrusion or lack of the expression of the genes that would result in a forward growing maxilla and the mandible coming forward. So these are all really important questions to explore.
Okay, so just again, so when we talk about these topics, because it is very interesting that the development of malocclusion can start as early as even the utero. So, so definitely, again, in order to make clear what we are doing differently from the mainstream of orthodontics, so there are two ways: that either we change the entire orthodontic specialty, or we create a form of orthodontics. So I think it's much easier to start like this, and then we have to define what kind of different orthodontic categories are existing. Certainly there are treatments that are concentrating on straightening the frontal teeth, the social 6 cosmetic treatments. This is category number 1. There are categories that are intended to define the structures only. So this is structural orthodontics or non-based orthodontics. And there should be an introduction of the third category, which is health-centered functional orthodontics. So I think definitely we have to introduce this kind of form of new category that helps us to establish the definition that this is the one that we have been practicing. And this is certainly a type of orthodontics that accepts the interconnectedness between the whole entire body. And we are talking about the general health of the patient. So this is not local health. This is not about bite, but we are responsible for the general health. So we have to establish a certain new category within the orthodontic specialty in order to make it clear that we are doing something different. So I think it is crucial to make it clear that this is a new category within the orthodontic specialty.
So Gabor, one of the things that we have begun to work on in conjunction with the American Dental Association and the Academy of Pediatric Dentistry, here, you know, the Academy of Pediatric Dentistry was instrumental jointly with the Academy of Pediatric Medicine about 20 years ago to have a defined, clear delineation of what constitutes early childhood caries. And it is any tooth decay that appears before the age of 71 months old. You know, one cavity is early childhood caries if you're under 6 years old. You've not yet reached age 6. And it's classified as severe if there's more than one. And there's some other, you know, caveats to that. But we need to do the same thing. And I think this could be a major goal of the International Orthodontic Society, is that we come up with a clear definition of what is early childhood malocclusion. That's any malocclusion that appears before the age of 6. And it's classified as severe if it also coincides with comorbidity with sleep and breathing. And we've already gone a long way in Steve Carstensen is a liaison with the American Dental Association, and we're trying to package it for him that he can take it so that we get this clear definition out. Well, I think this should, maybe the International Society will embrace this before the Academy of Pediatric Dentistry and the ADA. What's the matter with that? So I will gladly send everybody that is interested how we have defined this and how we qualify it, because there are at least 4 malocclusion phenotypes that will be evident in the primary dentition, will always persist beyond, usually worsen, and almost always coincide at some point with comorbidity with sleep and breathing disorder. And they are retrognathic maxillas and or mandibles first appear in the primary dentition, maybe even in utero, right? They will persist without some sort of intervention. They're usually myofunctionally related in terms of etiology. So there's retrognathia, upper and or lower, usually together, transverse deficiency in both arches, almost always together. This is McNamara, Bashara, major papers in the US that say that these don't go away. Once a class 2, always a class 2. The other one is vertical, anterior open bite, or deep bite. Those persist. In deep narrow palate, there they are. There's 4 things. They do not go away. They cannot go away. They persist, and they almost always are associated with myofunctional etiology and sleep and airway comorbidity. So, again, I'll share these definitions. You guys can maybe give us your input. Maybe we could, alter these definitions, make it easier for physicians to understand. We partially did it for caries so physicians would understand what is going on here. They're baby teeth, they fall out. What difference does it make if they have cavities? That used to be the attitude.
Sorry to cut you off, Kevin, but we're coming up on the hour. Where
yeah. And I just want to say we have some viewers out there that are saying, absolutely, we are in agreement. Sherry Klein, Dr. Boyd, I would love that information. Ella Banica, good point. Gabor, people are out there listening, supporting these ideas. So our job as we move forward is to distill them and put them into an organized format, which would be toward this white paper project. With that,
here say we should have a white paper on orthodontics and myofunctional therapy.
it sounds like we're going in that direction, Mark.
Everybody's thumbs up.
The momentum of the wave, it's beyond us now. It's already carrying us forward.
Oh, Dios mío, a 4th white paper.
Licha Pasque, you wanted to say something.
Yes, this relationship between myofunctional therapy and orthodontic therapy should be a section of an overall white paper, because it's like a jigsaw puzzle of which this aspect is one of the pieces. So as long as this piece sits prominently, it's fine, but there are other pieces that will need to come together.
Wonderful. I want to say thank you to everyone here today. Thank you, Marissa, and all of your, everyone who's here, and wonderful job. We will conclude for now and see you in 15 minutes.